our talk today is about updates on Parkinsonian syndromes, and actually it's a very huge topic, and I try to minimize it and talk to the special, actually almost like 3 known syndromes which we see a lot actually. 2 of them not common, 1 of them is common of course, and we'll try to give you an update, mostly of the clinical part, a little bit of neuroimaging, but I'll leave for Dr. Kirk Fife to control for the neuroimaging part. So in movement disorders, we actually divide things in 2 parts, the hypokinetic disorders and the hyperkinetic disorders. And the hypokinetic means is the slowness in movement, what we call the bradykinesia or hypokinesia. So, for example, examples of the hypokinetic disorders we see is Parkinson's disease, multiple system atrophy, progressive supranuclear palsy, corticobasal ganglionic degeneration, vascular Parkinsonism, dementia with Lewy Bodies, and frontotemporal lobar dementia with Parkinsonism. And the common thing is the Parkinsonian features, the hypokinesia in these syndromes. Now, the hyperkinetic disorder, which I am involved also, is the chorea, balismus, myoclonus, dystonia, tics, stereotypies. Some of my phenomenology will be very difficult to understand here, but I'm trying to simplify it here for you. Now, the Parkinsonian syndromes include the Idiopathic Parkinson Disease, which is the common which we see, progressive supranuclear palsy. The old terminology for progressive supranuclear palsy is the Richardson-Steele-Olszewski syndrome, but now they changed the phenomenology. Multiple system atrophy, we have 2 types, Parkinsonian and the cerebellar type. Before it was the striatonigral degeneration, Schrei-Drager, olivopontocerebellar. But now it's type P and C. And then we have the corticobasal degeneration syndrome, vascular, and dementia with Lewy Bodies. Now, when you approach patients with Parkinson's, those symptoms and signs need to be addressed, you know. For example, tremor, like a resting tremor with a re-emergent tremor, postural action, because that will give you a hint what you are dealing for, because as you know, Parkinson's disease is mostly a resting tremor. Most of them actually will not have a resting tremor. They can have a re-emergent tremor. For example, like when you just see the patient in your clinic, his hands actually is on his lap, and there's no tremor. But when you ask him to raise his arms, just wait a few seconds, you will notice a tremor reappear. That's called a re-emergent tremor, and that's very specific for Parkinson's disease. Bradykinesia, again, is another thing. It's a slow movements with reduced amplitude. So I ask the patient to do those movements, it gets slower, and that's called bradykinesia. Hypokinesia, again, is slow movements without reduction in amplitude. So he'll be slow like this without getting more slow in the amplitude. And it is common in progressive supranuclear palsy. Again, we have rigidity, cogwheeling versus lead pipe, and gait disturbance and postural instability. So this slide actually tells you what are the common symptoms and signs we face with patients with Parkinsonian syndromes. Now, not every patient, when you face in your clinic, when you see a tremor, it's Parkinson's disease. It's very important to dig more deeply in history, and physical examination. So for example, when a patient tells you, for the past, it happened initially, falling down when I stand up, only when I stand up, or I'm having urinary urgency, nocturia. You think there is early autonomic dysfunction because Parkinson's disease will not start with those symptoms. It usually happens later. The other thing, the patient will ask you, doctor, I'm falling. So you ask them, how do you fall? Is it backward or forward? Because backward is progressive supranuclear palsy. Forward fall is Parkinson's disease. But in Parkinson's disease, it usually happens later. But when it happens initially with progressive falls, you think that's not Parkinson. And then you have symmetric onset. Parkinson's disease usually is asymmetric, unilateral, but then it shifts to the other side a few months or later or a year. But in other ones like multiple system atrophy or PSP, it's usually symmetric. And then you have the brainstem symptoms and signs. Of course, eye movement abnormality, ataxia, pyramidal signs. Again, that's against idiopathic Parkinson disease. Early cognitive decline or early visual hallucinations. You think about dementia with Lewy bodies. Okay, and again, stimulus-sensitive myoclonus. Okay, that's not Parkinson disease. You think about multiple system atrophy versus corticobasal ganglionic degeneration. And then vertical gaze palsy. Actually, this is a very important sign which happens actually in progressive supranuclear palsy and not in Parkinson disease. The patient usually will have slowness, and I'll actually talk on this in a few minutes, a problem in the vertical eye movements. But again, when you examine an elderly patient in the 70s and you ask them to look up, a little bit difficulty for that, and that's normal. The problem is downward gaze. Okay, and then you have the ataxia, of course, and inspiratory stridor. And this is very pathognomonic for multiple system atrophy, either type P or type C. Parkinson disease will never have this stridor. And usually what I mean, that abnormal dysphonic sound from the vocal cord paralysis, and it's very an emergency, and patient will need actually a tracheostomy to relieve that. Again, sleep apnea it's not Parkinson disease. You think of multiple system atrophy. And cortical sensory deficit. Numbness, tingling, or patient cannot feel what he's touching, it's all, again, it's not Parkinson's disease. And the magic drug we use for Parkinson's disease is the cinnamate levodopa. Believe me, it's a magic drug, okay? But if you had a poor response to levodopa and you give a trial for 1 month, you have to go back. Am I dealing with Parkinson's disease or something else? So all these are the red flags which makes you differentiate, are we dealing with typical idiopathic Parkinson disease or atypical Parkinsonian syndromes? Again, to continue for the red flags, stepwise deterioration of Parkinsonism, repeated hand injury history, history of encephalitis, oculogyric crisis, abnormal eye movements up with patients on neuroleptics. Again, neuroleptic treatment at the onset of symptoms. Okay. I've seen in my clinic a lot of patients from psychiatric hospitals send me patients for Parkinson's disease. For God's sake, he's on Haldol for a long time. He need to be offered for like this 6 months, and then we assess for Parkinsonian features, all this stuff. And then strictly unilateral features after 3 years. Again, that's a red flag. And of course, MRI imaging of normal pressure hydrocephalus. And that again will be a red flag for typical Parkinson's disease. Now we'll talk about the idiopathic Parkinson disease. Okay, and it's entirely, so to diagnose it, it's entirely clinical. I don't order investigations. As a movement disorder specialist, when I see that, that's PD, I don't go for DAT scan, I don't go for even MRI, because I know MRI will be normal. So usually the age will be above 60, and keep in mind young onset Parkinson disease. And think about other differentials, young onset, Parkinsonian, tremor, think about Wilson disease. And so as a differential. Genetic testing is available for the young onset, and usually younger age at onset in Parkinson's disease is associated with longer survival and slower accrual of disability. Diagnostic criteria for typical idiopathic Parkinson's disease, you need to have bradykinesia, and either of typical resting tremor of 4 to 6 hertz, extrapyramidal rigidity, or postural instability. So the mnemonic is TRAP. It's for tremor, rigidity, akinesia, and postural instability. But you need bradykinesia first to establish the diagnosis and one of those symptoms. Now this is just a path slide. You can see this is the slide of the midbrain. That's normal. That's substantia nigra compacta. You can see the melanin neurons containing the pigment. And here that's the Parkinson's disease, and there is atrophy and the loss of the melanin pigments in Parkinson's disease. Again, that's the normal. Okay, and in substantia nigra, you can see the melanin component of the neurons, and here there's the absence in Parkinson's disease, which contains, of course, the dopamine. And this is, again, a past slide. You can see here this like intracytoplasmic inclusion bodies called Lewy Bodies. And this actually can be found in Parkinson's disease and in dementia with Lewy Bodies. So the natural history of Parkinson, the progression of the disease and the accumulation is variable. And the mean time from diagnosis to death is around 14 years. But again, every patient is different from the other. However, patient diagnosed in their 40s, the mean time is 24 years in terms of disease duration. Now, in the early disease manifestation, we'll talk about the non-motor part, because when you see a patient with Parkinson's disease, you think about motor, means the tremor, rigidity, bradykinesia, but don't forget the non-motor symptoms, and that actually is very deteriorating, and you need to involve in terms of management. So early disease symptoms include REM sleep behavior disorder, which means that the patient is acting out their dreams. While they're dreaming, they are kicking, shouting, and punching, and this is abnormal. Usually when you sleep, you don't move actually, or dream. Those patients, they are acting their dreams. And this REM sleep behavior usually occurs several years before Parkinson's disease, and also can be found in multiple system atrophy and dementia with Lewy bodies. Again, anosmia, loss of sensation of smell. Parkinson's disease usually lose this function years before developing the tremors and the rigidity. The other symptoms is constipation, psychiatric like depression, anxiety, fatigue, and early mild cognitive impairment. So all these could happen early on before the patient develops the full-blown symptoms and signs of typical motor. Now this is the progression of PD. So everybody when he thinks about Parkinson's disease, they think, oh, it's tremor, rigidity. But if you look at the slide here, the degeneration actually starts down in the medulla and progresses upward. Alzheimer's disease is the reverse of that. It starts upward and go downward. So that's why patients will have the REM sleep behavior, because the regulation in the pons is disrupted, and that's why they're acting out their dreams. Same thing with the smell. So that's why it starts early than the motor symptoms. Now the later stages is the reduced duration of effect of the oral medications, and you have the fluctuation, dysphagia, severe cognitive dysfunction, reduced mobility, depends on others, and usually the cause of death actually is bronchopneumonia and or aspiration pneumonia. And again, as I mentioned, when you ever face a patient with Parkinson's disease, you need to assess the motor symptoms, as I mentioned, and then the non-motor symptoms, the autonomic, the postural dizziness, hypotension, siluria, seborrhea, urinary urgency, frequency, nocturia, sleep pattern, mood, depression, anxiety. Depression is very important because if you don't treat depression, it's like a vicious cycle. The patient gets worse. You will increase the sentiment. The patient will not respond because he has depression. So you need to interfere with that. Okay. Also, we need to ask about impulsive control disorder, especially when patients on dopamine agonist. For example, heavy binge eating, spending money inappropriately, pornographies, staying on the internet till next day, and that's a complication actually from the dopamine agonist, plus also the miswiring in Parkinson's disease itself. So we need to ask those questions also. Now the treatment, again, the active treatment begins at the same diagnosis, but does not necessarily require medical therapy. If it is mild initially, you can wait and watch. And you need to counsel the patient in terms of support, delivery of information. The treatments available in terms of Parkinson's disease, we have the levodopa, which is called the Sinemet, and we have the 100 or 25, the 250, and we have also the catechol methyltransferase inhibitors such as entacapone, and we have also the dopamine agonists mentioned there, MAO inhibitors, rasagiline, selagiline, and amantadine. Actually, in Kuwait, we have a deficient in those medications, but in Adan Hospital, actually, I brought all medication there, so I'm happy now for the time being. So, initiation of dopaminergic therapies is dependent on patient's preference, degree of disability, and potential side effects of therapy. So, and usually when I say if it is young-onset Parkinson's disease at age 40, it's better to start on dopamine agonists rather than levodopa. And when the patient is presented in the 60s, it's better to present to give them the levodopa versus dopamine agonist. And the question here about is the dyskinesias, the involuntary movements, which can happen with levodopa. So, but this is the criteria happening worldwide. But I disagree. Why? Because when you have a young onset PD and he cannot function very well, dopamine agonist will work for a long time. But levodopa is very fast, and you will find a good functional improvement with levodopa. And of course, the advanced treatment here, we have the deep brain stimulation, subcutaneous apomorphine, and the duodopa. And deep brain stimulation surgery is reserved for patients who fail to improve on medications but who are responsive and who do not have psychiatric or cognitive and who do not have atypical red flags of PD. So the next topic here, we'll talk about the one point about the disease progression. Rasagiline is out there, which prevent disease progression, but it's not that good actually. But what usually I say to the patient is physical exercise, mental exercise, and social interaction. Those three things actually delay the progression of Parkinson's disease and also Alzheimer's disease. So it's important to inform the patient about that. The second one will be PSP, progressive pulmonary palsy. And the diagnosis should be considered in all patients who has Parkinson's symptoms or signs, not responding to levodopa, early postural instability and falls, and slowing the vertical saccades, downward more than upward, and then vertical palsy, saccadic intrusions, severe dysarthria and dysphagia. Recently now we have new subtypes of PSP. We have the Richardson syndrome, PSP Parkinson, pure akinesia with gait freezing, PSP Corticobasal, and PSP with frontotemporal dementia. Now, Richardson syndrome occurs around 65 years old, and usually the most important is the postural instability, falling backward, and the change in personality occurring very early, and visual disturbance. And the eye movements, again, you have saccadic intrusions. When you ask the patient to fixate on a distant object, you'll find abnormal eye movement back and forth. We call it square wave jerks. And you have the slowing of the vertical saccades, downward more than upward, and then eventually the vertical and horizontal will get knocked off. And that's very typical of PSP. And then with these eye movements, you will notice they will develop this midbrain atrophy. And you have this MRI picture. This is called, if you can see, this is the midbrain, and this is the pons. It's like a penguin or the hummingbird sign. Why is that? Because the pons is normal, but the midbrain is atrophied. And that will give you a picture. We call it the hummingbird or the penguin sign. And of course, they will not, those patients will not have autonomic features, and they can depend on other 3-4 years after the disease onset. And the mean disease duration is usually about 7 years. PSP Parkinson is very interesting disease because they can present with Parkinsonian features, with asymmetry, but they can have jerky action tremor and severe axial rigidity, which is actually not found in Richardson syndrome. And response to levodopa is in the early feature, but then that will dissipate. And usually this duration test is about 3 years. Helpful point for PSPP is rapid progression, prominent axial symptoms, suboptimal response to levodopa, and drug-induced dyskinesias are unusual. The other feature is we have the PSP with pure akinesia with great freezing. The patient presents to you with no tremors, nothing, but they have freezing of gait. They cannot walk. They are freeze, especially when they enter a narrow door. They say, "Doctor, I cannot walk. My feet is stuck on the floor." That's called freezing of gait. And that's actually a part of progressive supranuclear palsy. And they have some axial rigidity and neck rigidity as PSP. And the mean disease duration is about 10 years. PSP with Corticobasal syndrome is usually patient will present with unilateral idiomotor apraxia, difficulty using tools, non-levodopa responsive, myoclonus, stimulus sensitive, dystonia, and alien hand phenomena. The patient will tell you, "Whose hand is this? It's not my hand." That's part of the Corticobasal syndrome. And the non-motor features is aphasia, the cortical sensory deficit, and visuospatial deficits. And the last one will have the frontotemporal dementia, and those patients actually will have the personality changes, disinhibition, apathy, and the other one will be the progressive non-fluent aphasia or apraxia of speech. Those patients, 5 years from the presentation, they can develop features of PSP. So it's like a spectrum. Now they're saying PSP, corticobasal degeneration, and FTLD. It's like the whole spectrum of disease. Treatment-wise, we have support to the pharmacologic and multidisciplinary team. And again, we have the dopamine, levodopa, but again, the response is not that good if you compare to Parkinson's disease. And we have dopamine and amantadine is used also for gauge freezing. And anticholinergic should be avoided because they worsen the cognition. And the bladder can be treated with sulfanescin, which is M3 antagonist, and botulinum toxin can be used for blepharospasm and dystonia. The last thing we'll be talking about multiple system atrophy. We have two subtypes, as I mentioned, is type P and type C. And again, the early autonomic features, not the falls. Early falls is PSP. Now, early autonomic features means patient tell you, doctor, I'm lying on the bed. When I stand up, I feel dizzy and falling down. But be careful of, if he's on antihypertensive medication, of course they will have some dizziness and postural hypertension, but the pulse rate will give you the idea about that. I will talk about it. So early urinary urgency, early postural hypertension, constipation, early REM sleep behavior, early erectile dysfunction, very important, sleep apnea, early morning headaches, striders, and levodopa-induced facial dyskinesias are all features of multiple system atrophy, not in PSP or Parkinson's disease. And the neuroimaging here, we have, this is a case of multiple system atrophy type C. You find the hot cross bun sign, and that indicates the degeneration of the pontocerebellar fibers. And this again, another example, the hot cross bun sign in the pons. That's not specific for MSA type C. You can find it also in spinocerebellar ataxia, Mercado-Joseph syndrome. And the other feature is, this is the head of the caudate, this is the thalamus, this is the globus pallidus, and this is the putamen. Putamen atrophy with hypointensity and surrounded by hyperintensity from iron deposition. That's again typical of MSA type P, and this is MSA type C. Approximately 30% response to levodopa. Bradykinesia and rigidity progress faster than PD, and postural instability and falls emerge within the first 3 years of disease onset. And of course, in MSA type P, which is Parkinson, they have the Parkinsonian gait, narrow-based shuffling, and the MSA type C is the ataxic one, so you have the wide board-based gait. Resting tremor can be present, and what's pathognomonic is the action spontaneous and stimulus-sensitive distal myoclonus is more common in multi-system atrophy. So when you bring a pin and you just try to tap on the patient's finger, they will jump. That's not typical of Parkinson's disease, it's typical of MSA. So to aid in the diagnosis, again, in terms of blood pressure, we need to check the postural blood pressure in those patients. When autonomic failure is present, the blood pressure will fall by more than 20 millimeters systolic and or 10 millimeter diastolic on standing without increased in pulse rate. So if there's increase in pulse rate, you think that's postural hypertension from drug-induced, from antihypertensive. But when there's no increase in pulse rate, you think about autonomic failure. The median survivor of either of those MSA P or C is 8 years. And the factors predicting short distance survival is early autonomic failure, older age, short interval from disease onset, severe cognitive decline, unintelligible speech, severe dysphagia, using ongoing catheter use. All these are signs of bad prognosis. Lastly, about the treatment again, it's the multidisciplinary team. It's a neurologist, internal medicine, ENT, social worker, physiotherapy. We need to get along and help those patients. In terms of medication-wise, we have the dopaminergic medications. Approximately 1/3 of MSAP will benefit. 10% may improve more than 50% of their symptoms. And usually we start with levodopa, the 125, half a dose, and increase that on a weekly basis. You can go to up to 1,200 milligram, and you can see the effect in 1 month. Give it a time, 1 month. Don't say that patient is not responsive before that. Give a chance. Autonomic dysfunction, the non-pharmacological use, you ask the patient to, especially for postural hypotension. Patients always dizzy when standing up, blood pressure systolic is below 100. You tell them to increase the dietary salt intake, avoid caffeinated drinks because of dehydration, and discontinue any antihypertensive or reduce the dose. Get up slowly from a seated or lying position, wearing a thigh-high compression stockings and leg elevation while lying, and this will help to increase the blood pressure. In terms of medication, what we have to increase the blood pressure, we have the fludrocortisone, Florinef, and midodrine. If both are ineffective, you go for indomethacin or pyridoxine. But recently, on February 18, 2014, the FDA approved a new medication called droxidopa. It is an alpha-beta adrenergic agonist, which converts droxidopa to norepinephrine, and that will increase the blood pressure. The dose is 100 milligram TDS. The last dose, you give it 3 hours before going to bed because of the symptoms of supine hypertension. Lastly, so we have the urologic symptoms. In terms of urinary retention, incontinence are usually present early in multiple system atrophy. We do urodynamic studies to determine the type of defect, and usually we prescribe the M3 antagonists like solifenacin or darifenacin because they'll have less anticholinergic and will affect the cognition less likely than the other ones. And they can use also intermittent catheterization if needed. And lastly here, in terms of patients who have severe stridor, difficulty breathing, cervical, laryngeal, or in terms of from the dystonia, you can go off a tracheostomy, and it's very life-saving. I have a patient in Adana Hospital who have MSA type C, developed severe stridor, went to the ICU, and the family was hectic. No, don't do tracheostomy, he will pass away. I said, don't worry, he needs tracheostomy now. So after the tracheostomy, patient improved dramatically, and he's well and living in a good healthy well-being. Thank you very much. I apologize for the speed, and